Namaskar. Warm greetings to our Fogsi President, Dr. Sunita Tandulwadkar, and to our distinguished guest, Dr. Deepak Saxena. A very good evening to all our listeners tuning into Gyan Pravah, the podcast series. We are delighted to have you join us from across India and around the globe. Welcome to episode 308, brought to you by the Clinical Research Committee of Fogsi under the dynamic leadership of Dr. Sunita Tandulwadkar, President of Fogsi 2025. ज्ञान का बहता रोजाना एक नया अनोखा रंग, हर रात 8 बजे जुड़िए फॉक्सी के संग. I am Professor Dr. Surekha Taide, the chairperson of Clinical Research Committee of Fogsi and your host for this evening. I will start today's podcast by paying homage to my mother-in-law, Srimati Salunkabai Taide, who left for heavenly abode 2 days back on 29th of November at the age of 92 years. She always encouraged me in all my endeavors and upheld the principles of dedication, hard work, and honoring commitment. May she attain Sadgati. Today, it is my privilege to welcome Dr. Deepak Saxena, the Director of Indian Institute of Public Health, Gandhinagar. Together, we'll explore a topic of immense importance: water, hygiene, and sanitation in healthcare facilities and labor rooms. The experience from LMICs. It is my distinct pleasure and honor to welcome our very own President of Fogsi, Dr. Sunita Tandulwadkar, a visionary, a trailblazer, and a true architect of transformation in women's healthcare. Where vision meets action, there shines a guiding force. Dr. Sunita. From delivering India's first stem cell baby to leading initiatives like Sampurna, Eagle, and Gyan Pravah, she turns ideas into impact and dreams into direction. She has a great influence on all the healthcare workers and special interest in public health as well. She is an acclaimed IVF specialist, endoscopic surgeon, author, and mentor, and she wears many crowns, yet finds her greatest joy in helping others shine.
Please join me. Sureka. Thank you. Enough for me.
Over to you, ma'am.
Thank you. Thank you, Sureka, for your kind words always. And thank you for always bringing one of the best faculty. Dr. Deepak Saxena, welcome on a Fogsi platform. I heard and I read your whole biodata, working on a public health environment and so many things. I think it is a need of a time. We should be talking about it. We should be discussing about it. And more or less, we should be taking action on it. That's how we have to work. And I think this podcast will be of a great value to all who will listen, even if they contribute from their side, any suggestions which you give in our day-to-day practice, in our day-to-day life, we should be adopting, not just leaving it to the government that you do this and you do that. So, Surekha, thank you so much. You are one of my most dependable chairperson. Anything I give, within 24 hours, the work is done. The projects, what she is leading, I don't have to, you have to give a project to her. Following the project, doing all the necessary work with it. That is what today she is, I think, running 2 projects of 2 years back, President LSES with Dr. Rishikesh Pai, and with me from UNICEF for Sampurna. So, Sureka, fantastic. In no time, you connected me with the 50 hospital and taken the project to such a beautiful level that they are now want to do one more project with us. So thank you for being great help to Fogsi always. Dr. Deepak Saxena, lovely to meet you. And our protocol is I join the viewers link and listen to both of you. Having 300 plus podcasts joining every day 8 p.m. is a great pleasure for me because I get to meet you all. Thank you. Thank you for being with us. Thank you.
Thank you.
Thank you.
Thank you, ma'am. Thank you so much. Now it is my privilege to introduce Dr. Deepak Saxena, a highly respected academic leader and public health expert. Dr. Deepak Saxena is a physician and a public health expert currently serving as the director of the Indian Institute of Public Health Gandhinagar, IIPHG. He holds an MD in community medicine, a PhD in epidemiology, and completed his postdoctoral fellowship at the Karolinska Institute, Sweden. With over 2 decades of experience, Dr. Saxena's work focuses on emerging infectious diseases, antimicrobial resistance, and water, sanitation, and hygiene, WASH. He has led multiple large-scale, multicentric studies assessing WASH in the healthcare facilities, labor rooms, Anganwadi centers, and community settings across LMICs. He co-developed a WASH assessment tool in collaboration with the London School of Hygiene and Tropical Medicine and serves as the WHO Technical Advisory Group for evidence generation on WASH in healthcare facilities. Dr. Saxena also leads the Center for One Health and Research, supported by the University of Bonn, with focus areas including zoonotic diseases, AMR, health systems, surveillance, and biosecurity. He is currently spearheading initiatives on green and climate resilient healthcare facilities. He is widely recognized for his contributions to research, capacity building, and policy support, and serves as an editor and reviewer for several national and international public health journals. Welcome, sir.
Thank you. Namaste, madam.
So we will go ahead with our podcast today. And my question to you, sir, you have worked so much on WASH facilities and maternal health, and you have given such beautiful tools on WASH in healthcare facilities, especially in the context of maternal and newborn health. I would like to ask you, what drove you into focusing on WASH in healthcare specialties, especially in context of maternal and newborn health?
Thank you, Professor Taide. At the onset, I should thank Fogsi for giving me an opportunity to speak. I'll go back, IIPHG Gandhinagar has been working for more than a decade on WASH in healthcare facility. It all started, I'm sure all of you must be aware that there was inception of National Rural Health Mission with a focus on decline in MMR and IMR. And after some years, it was almost stagnant. The initial drop was quick, then it got stagnant. And while we were deliberating with few of our colleagues, we came across one wonderful paper from an obstetric epidemiologist from London School of Hygiene and Tropical Medicine, Professor Wendy Graham. And she mentioned very explicitly that, once there are saturation at the causes, you should start even targeting for cause number 2 and 3. And we started looking at the NFHS data. We came across sepsis as one of the important factors that actually can lead to maternal deaths. And we started looking for the reasons of sepsis. And that's where we started contacting Professor Wendy Graham. And we started writing some joint grants. And we were lucky enough to have got a grant for studying the WASH assessment in Bangladesh and in India. And that's where we actually came across focusing more on documenting WASH in healthcare facility with a very specific focus on what is known as labor rooms. So that's how the entire journey started. And since more than 2 decades, we started with Toolbox 1, Toolbox 2, Toolbox 3, and finally we are with Toolbox Plus that is also there. So that's where the entire inception or the journey of IIPHG Gandhinagar and London School of Hygiene and Tropical Medicine started working on WASH in healthcare facility. Thank you, ma'am.
Excellent, sir. Thank you. It's really nice to know about your collaboration and, of course, the work you're doing in the LMICs. For our listeners, sir, how would you define WASH in a healthcare facilities and why is it particularly critical in the labor rooms?
Yeah. Thank you, ma'am. I know sometimes we use certain words as, just because of saying something, but, WASH actually is a commitment. So it actually talks about water, sanitation, and hygiene. It refers for system, infrastructure, supplies, and behavior that should be there in any healthcare facility, very specifically to labor room, to ensure that there is safe and sufficient water, either for drinking, cleaning, medical procedures, sanitation facilities, toilets, waste disposals, and safety management of the human waste, and hygiene practices, whether we talk about hand hygiene supported by soap or hand rubs or clean surroundings. We should also focus when we talk about WASH on environmental cleaning. That is very important because there should be regular disinfections of the surfaces, and last but not the least, infection prevention and control practices and protocols. Now, coming to the question on why it is very critical for labor room and in fact very specific focus on mothers and newborns, because both are vulnerable. And when we talk about antenatal care, much of the stress is given on antenatal care, but equally true is there is something like postnatal care and there is something like sepsis. Unfortunately, in many of the LMICs, irrespective of type of the delivery, prescribing antimicrobial agent is a routine practice. Whether you talk about Bangladesh, Zanzibar, East Africa, or even in many of the states of India, whether it is normal delivery or whether it is episiotomy or whether it is a cesarean section, giving antimicrobial agent is a routine practice, and therefore, because they contemplate that will not be able to maintain optimal WASH and it can lead to infection, and maternal infection can also lead to the infection of the newborns, and therefore, it is very important. And more than that, you need to provide dignity and comfort to the delivering moms, and therefore, it is essential, critical to ensure optimal WASH, not only for prevention of maternal, but also prevention of neonatal sepsis, and thereby giving them a wonderful experience of the motherhood. Thank you, ma'am.
Yes, sir. And we talk of so many big things, advances, robotics, laparoscopy, and whatnot. And even in, prevention of maternal mortality, we talk of equipments, but simple thing as a running tap water and simple as a clean platform, as a clean floor. These things, may be neglected sometimes and maybe not given the due importance. If we just focus on these simple things, so many lives can be saved.
Very
Much morbidity can be prevented, and it's so very important that we focus on WASH. This should have been the everyday and word in not only public but in obstetric gynecology, but it is not so. That is it. That's why it is beauty that we create awareness, we do this sort of advocacy. So thank you for giving your whole life, I think, to this project and to this endeavor.
Thank you.
What is it? Sir.
And madam, you'll be surprised to know that, global data suggests that 50% of the healthcare facility and labor room still doesn't have optimal WASH facilities. And then we are talking about attainment of sustainable development goals and so on and so forth. A simple thing that actually is missed out. So it is pity.
I know.
Sorry, go ahead, please.
I have also been in the community. I have been working in Sevagram it's a rural medical college since last 25 years. And I have visited numerous PHCs, and I totally agree with you. Simple thing like a tap water, running water. A good toilet facility, a clean toilet to the laboring woman is still missing. We need to focus on this.
Yes.
Sir, regarding your WASH assessment tool you have co-developed with the London School of Hygiene and Tropical Medicine. So what gap does this tool aim to address? Would like to know from you.
Thank you, madam. When we started developing this tool, we really wanted to understand the gaps itself. So I'll focus on two simple things. One, the tool, or which is known as toolbox. At that time, when we have developed based on our observations in Bangladesh and in India and in Zanzibar, it was observed that there are three important things that you need to focus on. One, walkthrough, and you should be very clear about whether optimal wash facilities are available or not. If they are available, then is there any training need for those who are workers? They should be known, they should be aware about the use of these wash facilities. And above all, it was also important to understand and document the processes that are being followed. Two things which came out very explicit during our work, either in Bangladesh or in India, and that was the missing link. And the missing link or the gap was labor rooms were never under microbiological surveillance. So half of the time, what actually happened was they took proxy of microbiological surveillance to be clean surface. Now, when we generated a hypothesis, and hypothesis was visibly clean may not be microbiologically safe. So what we did a very simple exercise, and during that time, I'm sure many of those who are listening this podcast must have heard about photo voice technique. Now, photo voice technique was what we did in India and Dhaka, in Gujarat and in Dhaka, was we trained the healthcare providers with the ethics of photography. And at that time, we took 2-megapixel photograph and we asked them that snap in the labor room and labor wards the place which you feel is the cleanest. And once they have taken up these photographs, we had taken microbiological swabs. And when we had taken microbiological swabs, 80% of those swabs were found to be infected with 4 or more than 4 bacteria. And the worst part was yet to come, because 60% of these samples were found to be resistant to more than 4 commonly used antimicrobial agents. So the biggest gap was not visible surfaces, it was microbiologically safe surfaces. And when we started looking at who is getting the training, it was observed that for any training on IPC, either it was facility manager or doctor or the nurse, they have taken the training, but actually training was required to that cleaner, mopper, or the person who's actually the person who needs to ensure that it has been that he has been adequately trained. There were no protocols for what should be the dimension of mops. There were no protocols on how mop should be dried. There were no protocols on how long a mop can be used, because in Dhaka, in many places, we have seen right from t-shirts to denims to pillow covers, anything and everything on earth were used as mops. We started documenting it and had shared our observations with WHO. And you'll be surprised to know that even they were not very sure on what is the optimal protocol on changing the mop, on how to mop, till what time it should be dried, and whether there is a need for surveillance, microbiological surveillance of buckets and mops also. Just a quick finding, in our observation across India in 8 states and also in Dhaka and Zanzibar, the most infected piece of, the most important thing in a labor room or in a hospital was bucket and the mop. And we are still struggling that it was used to clean the infection or it was used to actually spread the infection. So these were some of our observations and gaps which led to inception of all our work. Thank you, ma'am.
Interesting. Very interesting. Just to know about the mop. And I can share the experience. First thing I enter a ward or a labor room is, I know I can smell also.
Yeah.
The mop was clean or not. And they really, I agree with you, whether that mop is used to clean or whether that mop is used to spread infection, the last word which you said. And it's so very important that we should have protocols in place, trainings, how to mop, what thing should be there, what sanitizer should we use, everything, it is so, and many a times where to store that mop. how to dry it later on. So very, very important. And I love the way you are giving all those examples on your lived experiences as well. Sir, this wash assessment tool, how does it differ from previous existing frameworks like the WashFit, and how has it performed as a tool in LMICs?
Thank you, ma'am. It's a wonderful question. In fact, Toolbox 1 came 1 year before WashFit was incepted. And majority of our observations were taken, and Toolbox actually was also referenced as being the base of developing WashFit. So two important things. In fact, I'll talk not only about WashFit, but I'll also like to draw your attention to kayakalp protocols. Whether you talk about WashFit or WashFit 2, which is the most recent one, or the kayakalp, which is there, they all are very subjective because they are based on ranks. Either it is fully compliant, partially compliant, or not compliant at all. And then it becomes pretty subjective. Something which you feel is not compliant, I may feel it is fully compliant. Unfortunately, the kayakalp was based on peer evaluation, and the evaluation that needs to be done only once a year. And therefore, if the month for kayakalp assessment is in January, they'll start preparing in December, and from February it will go back to haywire. They are again back on the same processes. WashFit 2 was a bit better because it actually talked about not only gaps but also about training needs. It also talked about it can be customized, but still it doesn't talk about the microbiological surveillance. It doesn't talk about the MOPS. It doesn't talk about the human resource, which is so very critical, especially in LMIC, where majority of the posts are contractual. Whether you go to a PHC or CHC, the cleaner and moppers are outsourced postage. And it comes up with certain stigma with reference to caste, especially in labor room. Those women which are carrying this placenta are to be thought from the most disadvantageous caste, and therefore not many would like to prefer for that job. They'll take it as a stopgap, and once they get an opportunity, they'll quickly leave. And therefore, once you train them, you retrain them, and all of a sudden you find that they are nowhere. So Toolbox actually was an iterative process. It was also having certain modules that can be used for any person, something like hands-on experience. So that's where kayakalp, WashFit, and Toolbox were different from each other, but the biggest difference was our stress on visibly clean may not be microbiologically safe. That is the difference which makes Toolbox a bit edge ahead of the contemporary tools. Thank you, ma'am.
So you're saying that as we take swabs from OTs from different surfaces and some areas, and we ensure that they are microbiologically safe, similar kind of practice, maybe not that rigorous, but to some extent should be there in the labor rooms and on the surfaces, platforms, what has been used. That is what I'm getting an idea.
Yeah, I'm a strong advocate of that. Why you take only in normal surgery or orthopedic surgery OTs or only ophthalmic OTs? You should do it for labor room too, because there are also in exposure, a female coming leaking, they're coming from various sections of society, they're in and out, they're struggling. And therefore, we strongly advocate, and I'm happy to share that at least in Gujarat, the policy advocacy was fruitful, and we were able to convince the government in ensuring that once in a fortnight, you should take microbiological swab. And in fact, if at all it is being found positive with certain bacteria like Pseudomonas and others, there should be a deep cleaning of the labor room so as to ensure that the prevention of sepsis can be done. Thank you, ma'am.
Absolutely wonderful work you're doing, sir. I really want to pay respect to you for this work. Sir,
Yes.
could you share an example where a simple wash intervention significantly changed the outcomes or the behavior in labor room?
Thank you, ma'am. So, once we were successful in Toolbox 1 and 2, we approached UNICEF, and we approached them and we shared them that we want to go for an interventional trial. We picked up 20 healthcare facilities. In 10, we did a simple intervention, and the simple intervention was training the moppers on how to mop the floor and mop the labor room, and having different buckets for labor rooms, for critical areas and areas like OPD. Otherwise, previously in Gujarat, where we used to find that one bucket was used for OPD, IPD in wards and also in labor room. And the outcome indicator that we measured was in terms of sepsis, in terms of the use of antimicrobial agents and duration of stay in the hospital. So, madam, simple intervention like the dimension of mop, drying of mop, use of different buckets was found at the end of 12 months statistically significant in reducing the rates of sepsis, and also in terms of the cost, because once she falls in sepsis, she'll have to have a longish duration of stay. She'll have to have broader antimicrobial agents. So even it was found to be more cost effective. That was one simple intervention that was given. The second simple intervention was given was adherence to IPC protocols. It's our moral responsibility to ensure that we should not spread the infection. And simple IPC protocols were mandatory. Now, unfortunately, there are many things which have been proposed by Government of India, but they are only on papers. Say for monthly meeting of IPC committee. Now, it's only on papers. It's only for a cup of tea and doing some halla gulla, and that's all. Unfortunately, it should be taken so very seriously, because it is directly linked with the lives of moms and also the kids. And therefore, simple interventions at the end of our package of intervention were found to be not only statistically significant, but were also found to be hugely cost effective. I quote one example, simple, and maybe, madam, if you can reflect on that. We were doing this work, similar intervention in Bihar and Uttar Pradesh. And during that time, we were telling that, is there a possibility of disinfecting the mops also? But then we were told that there is no light, the electricity or the power is not there for 12 to 18 hours. So what should be done? So, madam, we developed a solar cooker. It was a simple solar cooker that actually can be used for disinfecting the mops. And I'm happy to share that it was subjected for patent, and we were successful in securing that patent. So sometimes very simple things, even drying them in, in sunlight, having alternate mops for alternate day. So on Monday, this mop will be used, Tuesday, the second mop, and Wednesday, the first one. This simple, it's very cost effective, simple intervention that can be used at even PHC level, madam.
Excellent.
Thank you, ma'am.
Excellent. I mean, we look at so many big things, simple solutions using whatever resources we have. And like you said, just an alternative mops, alternate day, you just change the mops, you just dry them in the sun. So I think it is wonderful the way you're describing, and the concept of the solar cooker. I think these are the interventions which should be taken up widely in all the labor rooms. You have to advocate, you need to really, talk with the policymakers so that these things are adopted, and our moms and the neonates benefit from simple interventions, simple trainings, and simple protocols. So thank you very much again and again, sir, for doing the work you do. So, sir, from your experience, which wash indicator are most consistently neglected in the labor rooms of LMICs? Is it water availability? Is it the hand hygiene and sanitation? Or is it the cleaning protocol? We heard about cleaning protocols.
Yeah.
But other things, hand hygiene, what do you think, sir?
Thank you, ma'am. So two things. One, with investment into infrastructure, my observation from at least 6 states where we are working is infrastructure is there. There has been good amount of availability of continuous water in many of the healthcare facilities that we are in. Thanks to COVID, there is a lot more amount of stress on hand hygiene also. But still, what I feel is missing is protocols, or the behavior of adhering to protocols. In spite of knowing that this is so vital, in spite of them being trained, I'm not able to understand that why they don't take it so seriously. You talk about doctors, you talk about residents, you talk about nurses, you talk about cleaners, moppers. they are a bit clumsy. Sometimes I feel it's risk-taking behavior because risk is not on them, risk is on someone else, and therefore they do take this risk. So for me, my understanding is adherence to cleaning protocols that has been established, that has been evidence-based, that should be taken on priority, and reinforcement should be done. So there is no harm in telling someone, please don't do it, because it's not good for, not for you, but for the mom who is there in our hospital. So something which I feel is still being not taken very seriously. Even communities, supervision and monitoring. Think of him. Think of some lady who has come to a hospital in a PHC from a remote place, from a tribal community. For her, this is leisure of life. So even if you ask her, how was your experience? She'll say, oh, it was wow, it was wonderful because I could get a bed to sleep. I could get food for 2 days for being here. But nobody is there to ask her that, what you feel was inconvenient to you. And probably she'll say that, for me, the most inconvenient thing was to walk while leaking for 100 meters to go to a toilet, because many of the labor rooms were not having even an adjoining toilets. Simple protocols, simple things should be maintained. So that's my take on this. Thank you, ma'am. Go ahead.
Really, this thought-provoking, the discussion which we are having on mothers who bear so much and still think they are getting this 5-star facility. So really thought-provoking, and I think people listening to this podcast, especially I think policymakers, should give a thought on these. And of course, obstetrician just walking through in the labor room in their own footwear, walking in the street clothes. So many things we have to look into, and this is really one we should be looking into. Thank you very much, sir. About wash deficiencies, they contribute to maternal and neonatal infections. What is their link to antimicrobial resistance? You have been working so much on it. So your experience.
Thank you, ma'am. And as I shared earlier also, I'll quickly tell you that, giving antimicrobial agent irrespective of type of delivery is very common across globe. Either there is overuse or there is misuse or there is abuse of giving antimicrobial agents. One, there is no water, and therefore the obstetrician wants that, she should not have infection. She contemplates that, the lady will have the infection, and therefore a prophylactic antimicrobial agent is very common. Number two, because of scarcity of water, the same water is used to actually mop up different parts, critical and non-critical area within a hospital, and therefore there is more transmission of infection and leading to sepsis and leading to more use of antimicrobial agent, and finally leading up to what is known as none other than the antimicrobial resistance. It's also equally important that some of the water samples which we have taken from some healthcare facility, even they were having traces of the antimicrobial residues. So, sometimes it's a vicious cycle. So you need to understand, or, as program managers, policy planners, and important stakeholders for optimal maternal and newborn health, WASH is having a very, very direct link with none other than antimicrobial resistance or spreading of antimicrobial resistance. So my take is, there are some wonderful articles that were written by IIPHG Gandhinagar and colleagues, which actually has documented that there is a clear link for maintaining optimal WASH in reducing antimicrobial resistance. And also, I have been talking a lot about the women and other stakeholders, but also healthcare providers. Optimal WASH is not only important for them, but also for us as doctors, as nurses, as cleaners and moppers. And there is a direct link, madam, with antimicrobial resistance. Thank you, ma'am.
So, sir, let's now move on to your another initiative, which is Cohort and One Health. So you lead Cohort at IIPHG, focusing on One Health. How is WASH in healthcare facilities connected to the broader One Health framework?
Thank you, ma'am. It's a wonderful question, because whenever we talk about WASH, we have some sort of tubular vision that it is entirely linked on water, sanitation, and hygiene. We never talk about environment. We never talk beyond hospital premise. We never talk about, something which is in and around the hospital. And believe me, environment has not only micro, macro, inside and outside environment has got a very direct link of, One Health contributing to improvement of WASH in healthcare facilities. I don't want to quote any specific state, but there are many states where I have seen street dogs in and around moving into the vicinity. I have seen many primary healthcare facility where the neighborhood actually puts their buffaloes, their cats, and other big large cattle within the hospital premise. And therefore, it is important that presently the time has come where WASH in healthcare facilities should be also seen with the lens of One Health. I quote one example from South Gujarat where leptospirosis is almost endemic. Leptospirosis, it's caused by spirochete, and whenever there is flooding of water, it is excreted down in the animal urine. And there was a female who came for delivery, and then it was found that she came out to be leptospira positive, never been to any farm or never been to any flooded area or never been to a place where there can be a possibility, or never was in an occupation of even animal handler. Later on, the outbreak investigation or the investigation of how she could have contracted came out to be within the premise of the hospital where she acquired the infection because of. So, it's good time that we should think seriously. We should think it with the lens of One Health also. So that's my take on this. Thank you, ma'am.
I've been a clinician for so many years, and whenever we used to think of leptospira, we used to always think, oh, okay, this patient must have come from this village. The buffaloes are there where the milk is being produced, where the animal handlers are there. But this lens of cattle being there around in the hospital premises, really it is thought-provoking. We really need to think into all this. The policymakers, the managers of the hospital, everybody, the medical superintendent, everybody should really think into this. We cannot just talk of big things. These are small things. We really need to look into it, and really it is time now that we take care, and we take care of mothers seriously for that matter. Yeah. So, sir, according to you, see, whenever we try to do these things, there usually would be challenges. There would be gaps. So what is your main systemic barrier to sustaining good WASH practices regarding the policy gaps, some financing, human resources, or behavior change? What do you think is the biggest gap?
Yeah, thank you, madam. This, in fact, is a wonderful question. And for many years, I have been struggling to answer this question. So I'll answer it in two types. One, for sure, there are system gaps. When I talk about finances first, everything requires money. Unfortunately, there is no separate budget that has been allocated for maintenance of optimal WASH. It's there in the RKs is there, or some flexi pool money is available, but you have got priority to use those money. So there is no separate budget that has been given by the system. Our staff is contractual, and whenever we try to empower the human resource contractual staff, and the hospital facility manager does not feel that this is the person who actually should be trained, and therefore majority of the training goes only to doctors and nurses. So capacity building something is very important, and there is a clear-cut policy gap when we talk with reference to maintenance of optimal WASH. Government of Assam wanted us to do the costing, that what will the money be costed if at all I want to make my healthcare facility WASH compliant. And we did this study in 100 odd healthcare facilities across Assam, and the cost was minimal. The cost was so minimal, it was the cost of the tap, cost of the soap, cost of the mop. It was so minimal, but still for a policy person or for that facility manager, AC was priority number one, having a wheelchair was priority number two, having an easy chair for himself. Lot of things were wasted in infrastructure. They could have simply used some of the money which could have easily made it WASH compliant. I'm a supporter of kayak type of initiative, but I look it from a different lens also. Why it should be only once a year? It should be every day. Why you go to any airport, you go to a mall, even there is written that this toilet was clean now, or the last time this was done. Why it can't be practiced in a hospital, in a labor room, or in a ward that, we have done this? Why? Because we don't feel that ownership. Why? Because the patient has never asked. If I go to airport, if I see a clogged toilet, I'll quickly snap it and send it to a WhatsApp. And then, look, this is not done. Even for Indian Railways, they had put it. But for a hospital, there is no one to talk about it. Everyone is there to blame the doctors. Everyone is there to blame the system. But there is no ownership. So the ownership should come from doctors, and more than that, it should come from the community because they are using it. So why can't they ask a question, why it has not been changed? Why it has not been done? So, madam, it requires a systematic effort to ensure that policy is there, finances are there, and more than that, there is behavior change. There is behavior change that is not only there with doctors, but also with cleaners, moppers, and the society person. So that's my take, ma'am. Thank you.
We have to be clear about our priorities, what way we should, where we should invest and where we should focus. I think that is what all this is we are discussing. So whom to prioritize and where to prioritize, where
And
our
what
money
to
should.
Yeah.
Exactly. So definitely, sir. Sir, you're also leading the work on climate resilient green healthcare facilities. I've been to your setup. We also talk about heat action plans. So many things, you're getting that you're working as a, team over all these things coming together. So how is climate change impacting wash in labor room and health facilities and your experience about it?
Yeah. There are enough and great evidences, madam, that climate change has got a direct impact on maternal health and the newborn health also. Now, Government of India as a policy had put up a program, and the name of that program is National Program for documenting the impact of climate change on human health. But my argument is it is only restricted to, wastewater and water. They have not taken healthcare facility also as a center. So in Gujarat, with help of one foundation, we are trying to develop 5 healthcare facilities, which can be model healthcare facility, which not only talk about wash, but also try to talk about making the healthcare facility green and climate resilient. One of the important steps that actually can be taken up is use of solar energy. Now, solar energy can ensure that there is, disinfection type of things can be taken care of. Recharging the primary health centers, because a lot of water is drained out. So if there is a facility of recharging the water bodies which are there, and that can actually be used. But most importantly, madam, what I feel is it will take some years from now, but we need to ensure that our healthcare facilities should be climate resilient. If there is no water, how can we really maintain or adhere to wash facility? We need to ensure that waste, whatever is being generated, can be recycled, reused, and therefore, maybe in a couple of years, a lot of impetus is presently being given to green and clean healthcare facilities, climate resilient healthcare facilities. And I'm sure that very soon the guidelines that were developed by IIPHG Gandhinagar will be adopted by the national government. So I'm looking forward for that, and we'll keep Fogsi involved in the stakeholder engagement to tell them that what actually can be done at local level. Thank you, ma'am.
Thank you, sir. I think you have got one big great fan today of yours in this podcast, and that is me for the work you're doing. And definitely your work should be honored, I think, at the national level, at the international level, the work you're doing and the dedication with which you're working on, the moms, the neonates, and saving lives. So really, sir, great respects to you for this.
Thank you.
Sir, we are coming at the end of our discussion, and I would like you to recommend one priority action for policymakers and hospital leaders to strengthen wash in labor rooms across alumni. So what would be that one recommendation from your side?
Yeah. Madam, policies are now coming in place. There are many policies. Please implement it. Please implement it, monitor it, supervise it. And there is not everything is linked with money. There are mechanisms of recognition. They can be non-monetary recognition. So if your IIPHG or mopper or cleaner is doing great work at local level, once in a month, put her a photograph that, star of the month. So she'll feel recognized, she'll feel empowered. So some simple things at local level. At policy level, what I strongly feel is, WASH is multi-sectoral. It requires take up from many departments. Take it seriously. You can't leave it WASH only in books. You can't leave WASH just in PowerPoint presentation that, we had maintained infrastructure, training, optimal protocols, ensuring all stakeholders on same page can actually assist government not only achievement of SDGs, or we can foster our race in attainment of SDGs, but will also build up the confidence of cleaners, moppers, doctors, obstetricians, pediatricians, and also the community. So that's my take. Something like Modi ji did, Swachh Bharat Abhiyan. We need to talk about, Swasth Bharat Abhiyan, and Swasth should start from hospitals. That's my take. Thank you, ma'am.
Thank you so very much, sir. We are coming to the close of this enlightening episode of Gyan Pravah, and I would extend my heartfelt gratitude to you, Dr. Deepak Saxena, for sharing your remarkable journey and deep insights into WASH and reminding us how science, skill, compassion, simple solutions, prioritizing, training, capacity building, all can come together to save maternal and neonatal lives. Thank you so much, sir.
Thank you, ma'am. Thank you.
Special thanks to Dr. Sunita Tandulwadkar, the president of Fogsi 2025, whose visionary leadership continues to inspire and empower meaningful dialogues. And to our listeners, thank you for joining us today. Your curiosity and commitment to advancing healthcare keep this conversation alive and purposeful. Stay tuned for more thought-provoking episodes of Gyan Pravah. I, Dr. Surekha Taide, and Dr. Deepak Saxena, signing off. Until next time, keep listening, keep learning, and keep your hearts open. Take care and good evening.